Dr. Prashant, you may start now.
So, good evening, everyone. At the outset, I am Dr. Prashant Agarwal. On behalf of Mankind Pharma Medical Affairs, welcome you all to this session of Prevailing Care and Challenges of Managing Diabetes in India. Listen from the experts. So, just a brief about Mankind Pharma. Mankind Pharma in the year 1990, it was established in 1995, and in this year, it completed 25 years in the pharmaceutical industry. And in all those years, our vision have always been the most admired Indian pharma company. Mankind Pharma is committed to three pillars of serving life: affordability, reach, and quality of medicines. We have strong presence across therapy areas such as anti-infective, gastro, cardio, anti-diabetic, to name a few. We have a world-class research and development capabilities situated at Manesar, Gurgaon, which we have new drug discovery and research, active pharmaceutical ingredient capabilities, along with clinical research and global regulatory specialties. In the time of COVID-19, mankind wanted to give back to the society, and we did actually, and like we contributed, company contributed 51 crore, which were donated to PM Care Fund. All the employees of Mankind Pharma donated 1 day's salary to the PM Care Fund. We have distributed more masks, medical equipment, sanitizer bottles, and PPE kits in the volume of lakhs to our caregivers. With this, I always believe that it is the partnership between us and the doctors which actually leads us to this stage. So we thank you for your continuous support and encouragement for us. Now, with this, I welcome you all to enjoy this session, as there are not going to be any PPTs, but more importantly, our stalwarts of diabetes in India or world, they will be sharing their thoughts and their experiences. And to moderate this session, we have none other than Dr. Rajiv Kovil sir. Dr. Rajiv Kovil sir is the medical director at the Kovil Diabetes Specialty Center and also the visiting faculty at DY Patil University, Mumbai. So with this, I hand over this session to Dr. Rajiv Kovil sir.
Thank you, Dr. Prashant Agarwal. Thank you, Mankind Pharma. 2020 has been something that we all could have erased from our memory, but it has taught us a lot of lessons. A pandemic which made us realize that we have to be self-sufficient. But long before the pandemic came in, diabetes and the metabolic abnormalities of diabetes was already getting into an epidemic of chronic kidney disease and cardiovascular disease. And that's why we are here. 14th of November is World Diabetes Day. And we have got 4 stalwarts from India who have actually made India proud on the global scene. I call them all as global Indians. So let me introduce our 4 panelists and speakers. First one is Dr. V. Mohan. He's the chairman and chief diabetologist of Dr. Mohan's Diabetes Specialty Center, which is a WHO collaborating center for NCD and an IDF Center of Education. He's the director and chief of diabetes research at the Madras Diabetes Research Foundation and the ICMR Advanced Center for Genomics of Diabetes. Dr. Shashank Joshi is the chair of IDF Southeast Asia. He is also the dean of the Indian College of Physicians, endocrinologist at Joshi Clinic, Leelavati Hospital, and Bhatia Hospital. And again, the member of the COVID-19 task force, and he's a Marathi Manus. Dr. S.K. Wangnu is the senior consultant endocrinologist and diabetologist at the Apollo Center for Obesity, Diabetes, and Endocrinology at New Delhi. Dr. Shubhankar Chaudhary, professor and head, Department of Endocrinology, IPG, and SSKM Hospital, Calcutta. Thank you so much, all of you all, for being here. And it's going to be a 45-50 minute of crisp discussion on various aspects of non-communicable diseases, mainly in the metabolic domain. And I would start off by asking Dr. Mohan the first question. Sir, the prevalence of diabetes has been going up. So has the prevalence of complications. So coming from Chennai, why do you think that this has happened? And is it a pan-Indian phenomenon?
So thank you, Rajiv. First of all, let me thank Mankind for arranging this, and thank you for moderating this symposium. It's a great honor to join Dr. Shashank Joshi, Dr. Subhash Wangnu, and Dr. Shubhankar Chaudhary. My just thinking that the 4 metros have been represented: Mumbai, Delhi, Calcutta, and Chennai. So coming back to your question, yes, is the prevalence of diabetes increasing? Yeah, no doubt about it. I mean, in 1970s, we had 2% of urban Indians and 1% of rural Indians having diabetes. And we saw it go up. And the cities which have studied it, the maximum are Delhi and Chennai, where we've had the repeated surveys, at least every 3-4 years, a survey coming in. And you can see, and the same has been good when the other cities like Mumbai or Kolkata or Hyderabad or Bangalore have been studied, they are almost identical. There's no difference. So from 2%, it went to 4, 6, 8, 10, 12, 14, 16, 18, 20, 25% is what is now recorded in both Mumbai, both in Delhi and Chennai, according to the CARS survey, which is the latest which has been done. So there is no doubt at all. And in rural areas also from 1%, it's gone to, in Kerala, it's 20% in the rural areas as well. In other areas, it may differ. In Jharkhand, for example, it's only 3% or 4%. So India is so varied that in each state is like a country by itself with completely different characteristics. But having said that, that's at least a 4 times, if not a 20 times increase in prevalence of diabetes. So has the prevalence of complications gone up? Well, may not be in terms of the percentage of the total number of diabetics if you take. It's probably remained the constant or probably slightly come down because of better control of diabetes. Certainly, the cardiovascular disease, we know, is slowly coming down thanks to better BP control, lipid control, and sugar control. As far as retinopathy, nephropathy, and neuropathy is concerned, we don't have data that's actually come down. It's probably about the same. And we have the published figures from the CURE study, where about 18% of people, and this is actually confirmed by 4 different surveys from Arvind Eye Hospital, from LV Prasad, as well as from Shankar Nethralaya. We all got the same figures. Done 4 different surveys, all got 18%. So it must be true. So 18% have retinopathy. Slightly more have nephropathy if you include, or diabetic kidney disease, include microalbuminuria. Peripheral vascular disease is as common as nephropathy. And the PVD alone is slightly lower because we get type 2 diabetes at younger age. And of course, heart disease, we've always shown at least 1 in 5 have it. So 20 to 25% have heart disease. So these prevalences, the percentages may not have gone up. It might have slightly come down. But if you see the population of number of people who have had diabetes, 20 years ago, it was 32 million. Then it became people with diabetes in India. Then it became 40, 50, 60, 70. The latest figure was 77 million about 2-3 years ago. So I use the figure 80 million now because 2-3 years have passed now. So 80 million people in India having diabetes. Whatever you do the maths, percentage-wise 20%, it's definitely going to be more number of people with retinopathy, nephropathy, and so on because of the sheer population increasing, number of people with diabetes increasing. So we've got lot of work to do if we want to make India a complications-free diabetic capital of the world. So it's probably going to become the diabetes capital of the world because age is an irreversible factor. So even as we grow older, India is going to become an older nation. So, and age is one of the factors you cannot prevent. So I will never say that it's a diabetes-free India. That's never going to happen. It's like aging. You'll have more diabetes, more hypertension as you grow. But a complications-free India is definitely possible. And that's what we should all aim for on this World Diabetes Day.
Thank you so much, Dr. Mohan. I would ask Dr. Shubhankar Chaudhary, Dr. Shashank Joshi, and Dr. Wangnu also to chip in on this. How do we, the prevalence, has it been increasing, and the prevalence of complications? What are your views on that? Dr. Chaudhary, for you to start off, please.
Well, thank you once again, Mankind and Rajiv, and it's a great company to be in this evening. As Dr. Mohan has also indicated, the reasons for increase are several-fold, one of which is that the population is aging. The other is the nutritional improvement has overall taken place, and so people can eat better all over the country. And so the manifestation has been shown. And third, of course, with awareness, more detection is happening. But this apart, of course, the issue of lifestyle factors, genetic factors, which are there. And to my mind, possibly the single most important area where we can sort of make a dent in terms of the overall prevalence of diabetes in our country, I feel, is to improve, to harp upon improvement of physical exercise. A diet is so very varied, it's very difficult to give one specific advice which will apply all across the country. We can't just talk in terms of 50% carbohydrate and 20% fat or whatever. You have to be more specific, and that becomes very challenging in our vast country. So I think exercise is one area where we need to highlight. I mean, that's my personal view. And in that context, I think there is a lot that society, that government, that municipality has to chip in. It's not just my advice, or Professor Mohan's advice, or Dr. Wang Nu's advice that will work. You have to have the space for people to walk in. I mean, wherever, even in Mumbai, if you ask someone to go for exercise, pat comes the reply, where do I do? And where's the space? So these are all things that we need to think in order to bring about a change, a real big change. And complications, I fully agree. Overall, the numbers are much bigger these days. So we do see a much bigger number of complications. But in the same breath, I would say, for example, I practice in a government hospital setup, in my teaching institute, and I also have a private practice. So at least let's talk of, if I talk of the institute that I represent, where a lot of lower socioeconomic people do come in. I often see the ones which are admitted with diabetic foot ulcers are the ones whom we have never seen before in our clinics. However, the ones that we are regularly following up definitely show less of the complications. So I think there's a lesson to be learned from there, though there's not a properly studied information that I'm providing. But if you have regular follow-ups, I'm sure that helps to keep the complications down. I won't go further right now. Yeah.
Thank you. Dr. Shashank, your views on this?
So, Rajiv, first of all, thank you so much for having me on the show with Dr. Mohan, Dr. Shubhankar, and Dr. Bangnu. I must thank Mankind. So I have a dual hat. One is the IDF hat, and the second is, of course, as a personal opinion. So let me tell you the IDF hat. And IDF is very clear about what its mandate is. That every 7 seconds, we are losing a person living with diabetes on planet Earth. So the mortality is huge. And if you look at the lifespan of a diabetic lives 8 to 10 years less than normal human beings. So the first thing which we need to do is improve the lifespan of a diabetic. And the reason there is mortality in diabetics and a shorter lifespan in diabetics is fundamentally because of complications. So I think two things are very clear cut, that we should definitely aim at reducing the prevalence of diabetes in India. I think that can happen by better activity, lesser food, lesser quantity of food. That's very, very doable. But beyond that, I think to make complications-free world in diabetes, we have micro and microvascular complications. And for both of these, we need a sustained effort to screen them, because we are detecting them very late. We need to have a amputation-free India in the diabetic space. We definitely need to have a blindness-free India from the eye space. We definitely need to have a dialysis-free India from the kidney space. We need to have an angioplasty or a bypass surgery-free space in the heart space. So I think this is all very doable. And I think what is doable, we should do. So I think we have to be all committed with a common goal, a common theme, to make a difference in people living with diabetes. And I think there are two different diseases when we talk of diabetes. One is type 1 diabetes, which is an autoimmune disease, which is clearly delineating that this is something which is chronic, and that's something which we need to ensure that we need to handle type 1 diabetes as a separate disease from the garden variety type 2 diabetes, because diabetes has a lot of clusters, and it's important to recognize them, and each one of them we need to handle that with a war footing. Diabetes is like a tsunami, and its complications are the tsunami which we can halt. And I think that's something which we can do. So Rajiv, we have to be committed to increase the lifespan of a diabetic and probably have a complications-free India. I think we had a mission in 2011 when I was RSSDI president, and Dr. Mohan followed me after that, was to make a diabetes care capital of the world. We lost our first rank. I'm certain that probably we still are world number one, because China knowing China and their numbers, Dr. Mohan will agree with me that we have the challenges of numbers. But I think very clearly we should be the diabetes care capital of the world. And definitely we should aim at a longer life for people living with diabetes and a complication-free diabetes.
Thank you, Dr. Shan. Dr. Wangnu, your thoughts, please.
Thank you, Rajiv, and thank you, Mankind. I think all the three experts have beautifully explained the rising prevalence of diabetes in our continent. And what I have seen, what I have observed over the last 35 years from my practice, that what we used to see about 2 or 3 decades back, we are seeing more and more younger population suffering from type 2 diabetes. That is number one. And more people equally having what you call the equal number having pre-diabetes, what you call the insulin resistant state. We often basically miss them unless until we screen the family members for the pre-diabetes. So one thing is the screening of the pre-diabetic patient and taking proper lifestyle modification in this population. And number second, the young onset type 2 diabetes is increasing like anything, which I have been observing in my clinic. Third thing, equally important that we have to tackle right from the birth, the incidence of gestational diabetes mellitus, particularly in the females, is again on the rise. And what do you call the fetal origin of the adult disease, we have to tackle the maternal nutrition, whether it's the malnutrition or overnutrition, to basically prevent the development of insulin resistance in the offspring of that mother. These are three important factors. Apart from all of them have beautifully explained the role of lifestyle, the role of environmental factors, the role of genetics. And Dr. Mohan has equally highlighted about the geographical variation within the country about the incidence and the prevalence of diabetes, which is again very important, that might be linked to the genetic predisposition or the change in the dietary habits. That is very important. So what I think what we need to do is to pick up more and more younger generation of diabetics, more and more patients with pre-diabetes, give them proper education and take them through the lifestyle modification. At least that is the only way by which we can reduce the prevalence or the incidence of diabetes in our country.
Thank you so much, Dr. Wangnu. So if you could just move on, Dr. Shubhankar Chaudhary, I would like to ask that you spoke about how you could involve the municipal corporation. You work in a private setup as well as a teacher in an institutional setup. Now, how can means all of four of you all are stalwarts in diabetes and influencers in this chronic care field, and the influencers and the healthcare policy makers will surely sit up and listen to all of you all if you make an effort and tell them what needs to change. Does nutrition need to change? Do children need to be taught better about nutrition in their school books? Should nutrition be and exercise you mentioned should be inculcated as a curriculum? What are the changes in the healthcare which can make a difference in the next 20-25 years? As Shashank said that we should have a diabetes complication free India. How do we make it at a primordial prevention? What can be a good concept, you feel?
Absolutely. I think for a country like us, we should invest monetarily or otherwise in sort of primordial prevention. That calls for a lot of effort though. And these changes can definitely be helped, influenced by individuals, but it will also benefit if our associations, our RSSDI, for example, or Endocrine Society, for example, could come together, and they have come together and they have put the proposals as well in the past, if that could be done in a more concerted fashion. Let's say you did mention about exercise, and we have been telling, for example, we all know children, the kids, they have to run after school. They have to go to 3 tuitions many a time, different subjects they have to go. And so they don't have the time also for any physical exercise, and we can't blame them. So I have suggested, this is not yet been taken up. So if some sort of physical exercise is part of the curriculum, which it is in a sort of namesake way, but if it's evaluated, marked at the examination, something related to physical activity, physical build, etc., then the parents will also be taking care that their students do well in that category. And so that may be a sort of force for them to make them do the exercise. And similarly, absolutely right from the very basic textbooks should have definitely advised some ingredients about healthy eating and all that. So all these are definitely important. And I think beyond individuals, we should also come together as bodies and try and put our influence. And I know, I mean, we have even in this small group, we have people who are quite important, who have had national recognitions and who can also chip in their own personal way.
Thank you so much, Dr. Chaudhary. Dr. Mohan, you have done a research on all this in how low income versus middle income, and you've made them go to parks and seen the differences emerge over decades. Do you think that the government should take note and maybe change a few policies, and maybe that could change the next generation quite a bit? Because my daughter is 18, she doesn't understand parks, she's never been to parks.
Thank you, Rajiv. Yeah, see, even you're quite right. About 20, 30 years ago, we had the impression that diabetes is a disease of rich people. And so only the rich need to worry about diabetes. Only they can eat proper food. And so India, the food supply itself was in a big question mark before the 1970s. And then the Green Revolution came, and with that, India became self-sufficient in food. Today, we probably have excess food. I'm not saying that everybody has food. There are pockets where there are malnutrition even today. People are still starving in some parts of India, definitely not in South India. But there are some pockets of India where there is still, but that's a distribution problem. It's not that India doesn't have enough food. If you take enough food and divide it among its 1.36 billion people, there is enough food. Okay. So that's a different issue. It's a political issue. How do we make it available to the people? But the point I'm trying to say is that 30 years ago, when we thought of diabetes, we thought it's an upper middle class and above disease. We didn't even think that, in fact, data also, the first data, the CUP study that we did, the prevalence of diabetes in the poor people in the slums is about 6%, whereas it was 12.5% in the middle class, the real rich people we left out, because that was a very small percentage as well. So it was almost double. 10 years later, when we repeated in the same colonies, it is not in some other colony, so there cannot be, oh, you sampled somewhere else. The very same colonies, when the very same slums, when we sampled, we found that the prevalence had become equal. It was 15.5 in both. That means the middle income group, of course, the middle income group, there was an intervention. You mentioned the park. And so that was a park where there was a park built. That colony had a park built. And therefore, the Asiatic colony became a big success story. The people built the park themselves. And therefore, their exercise levels went up dramatically. And therefore, their diabetes only went up from 12 to 15%. Meanwhile, the poor people whom we thought would have gone from 6 to 8 or 9 went from 6 to 15% because they didn't have any opportunity to go to a park or anything like that. Their priorities itself were very different. So then we began to understand that if we had consciously done it, it was actually unethical because we thought they will not get. So it is a big learning point for us that even the poor people are going to get diabetes. More recently, when we did the INDIAB study and started looking at every state, and I know that two of the PIs are already here. Dr. Shubhankar Chaudhary is here representing the state of West Bengal, and Dr. Shashank Joshi representing the state of Maharashtra. And I was a PI for Tamil Nadu. So we already have 3 states here. So what we realized from that is that in the richer states, the more affluent states, today in urban areas, not in rural areas, in urban areas, today the poor people are having actually more diabetes than the richer people because the richer people are taking care of themselves. They're able to go to parks or gyms or whatever, or they have a gym in their own house. Plus, they're able to buy the healthier food. They're able to buy the fruits and vegetables and so on, which are very, very expensive. For a poor person going and buying an apple or an orange or buying good, healthy vegetables is not possible. We talk about organic vegetable, even on organic, any vegetable to go and buy is very, very expensive. Talking about onions getting more expensive and potato getting more expensive. So that's the state of the poor people. So I won't be surprised if 10 years from now, it becomes a disease of the poor. So the rich will take care of themselves. As it happened, it may double among the poor people. And the problem is they cannot even look after themselves. They don't have the wherewithal to do that. And they don't have they don't have the education to look after themselves. You'll also find complications actually coming in the poor. Where do they know about going for an early checkup or a regular checkup? Regularity of checkup was mentioned earlier. Very, very important factor. Are these people going to be compliant? They're not going to be compliant. The rich people will be compliant. Oh, my checkup is due 2 months, 3 months. I have to go and meet Dr. Shubhank Chaudhary. They'll remember that and they'll go, or Dr. Wang, and they'll remember that. Whereas here, it is not possible. So ultimately, we are going to be stuck with this. And the only way for that is the government to wake up. Already, a lot of the governments are providing free treatments. They're providing free insulins. They're providing whatever care that's possible. And through the Ayushman Bharat program that we have, we are also bringing in wellness clinics, which are supposed to prevent diabetes, identify diabetes early in the pre-diabetic stage, reverse it at that particular stage. It's all being done, but it needs a lot of continued effort, a lot of continuous education. We have to reach out to the people. And that is where I think programs such as this, if we are able to actually take it to the community and make people understand. Now, today, when we ask people to come for a checkup, they think, oh, they're calling us because they want to make more money. No, once more they see us, they'll get one more consultation and one more test. That is what they're calling us for. They don't realize the actual importance of it. But once they realize that it is some statement Dr. Shashank Joshi and I keep saying every time is that it is not costly to treat diabetes. It is costly not to treat diabetes. Because if you don't treat diabetes, you're going to end complications. And those complications can cost a bomb. It can, if you talk about dialysis and transplantation, your whole life is ruined. You'll have to sell your house to continue to do transplantation in the case of a middle-class person. So I think that is where the government has to wake up, give a lot of importance to non-communicable disease. It was just coming and then COVID hit us. So now again, the whole focus, we have been set back by 5 years now. So again, to come back and to bring diabetes to the center stage, in one way, COVID was good because it brought out that if you have uncontrolled diabetes, your mortality is higher and the outcomes are bad. So that at least was a wake-up call, both for the government and the people. I think the focus going back to saying that COVID will go away. Another year or so, COVID may become history in India, but diabetes is not going to go away. True. And right now, if you see, the number of people who die every year due to diabetes is far more than the total number of COVID deaths put together. Right, so I think we must get our priorities right.
Right. Dr. Wangnu, your take on what can you do to change the healthcare scenario?
Yeah, Dr. Rajiv, I think all said and done, and Dr. Mohan has beautifully explained. But what I think, we know the data, we know the increased prevalence, we know the lacunae where we are lacking in giving the healthcare system to the masses. But what as a medical profession we have done, number one, what the government has done for them. I think empowering patients, making them more aware and educate about their diabetes and its complication. And we know the patient who knows the most lives the most. That is number one. Number two, availability, affordability, accessibility of the basic healthcare system at the remotest areas of the country is the need of the hour. We have so much of data with us, but implementation of all the health policies, which has to be taken at a grassroots level, and it involves all the machinery, basically government, non-governmental organization, to make it happen. And so far in last so many decades, what we have done so far, we have produced data about the prevalence, incidence, complication. So what have we done for the masses? And Dr. Mohan has rightly said that how the poor people are suffering from diabetes and this complication. We have no health policy for them. We have no insurance for them. Each and every patient is spending out of his own pocket. So how the poor guy is going to treat himself and treat complications? None of the insurance companies come forward to make insurance for the diabetic patient if it's a diabetic patient. I think government has to change its policy about the masses, about the poor. There's so many Jan Aushadhis which are basically spread all over the country. are stocking only few medicines, basically. And if our patient goes and he says that this medicine is not available, I know that we are writing generic medicine, people are getting some subsidized rate of medicine, but sometimes the stock is not there. Patient has to travel a lot of distance because these Jan Aushadhis are not each and every nook and corner of the city. Delhi is a big city. So government had to make some, what do you call, the dramatic changes in the health policy as we are having in some other countries where we have to allocate a huge budget for the healthcare system. And nowadays, see, we can see that our defense budget is becoming more and more fat, but our health budget is getting more and more thinner. So I think all said and done, we have to implement, we have to do something, we have to empower our patient, we have to change our health policies and affordable accessibility, availability of the basic healthcare system to the masses. This is my view.
Thank you, sir. Dr. Shashank, you are in the COVID task force. So I think you should be in the diabetes task force once COVID is gone, and what can be done then?
So I'm a part of the NCD task force for the last government. And unfortunately, what I'm saying may be very bitter because, we have neglected diabetes big time. Diabetes gets plugged as a part of NCD with heart disease, stroke, and all cardiologists and other people are sitting there. Well, diabetes needs to be on the forefront. So I think the first thing is diabetes needs its own identity, and they need to take care of diabetics. So I think the diabetes kills much more than all other people. Actually, in COVID, diabetes is back on spotlight because it's a very important comorbidity. And because it's a comorbidity where people die, people and the government both are recognizing the need. The biggest problem in India is that we are supposed to spend 4% of our GDP for health. We don't even spend 0.5% of our GDP for health. So that's the first problem. Second thing is our focus on prevention. It has to be a mass movement. I'm not here to blame the government. I think it has to be a joint exercise by the government as well as the people at large. And it has to be a cooperative movement where we are able to do simple things which make a difference. There's no point talking in all these web programs and all these studios unless and until we do physical activity, unless and until we eat less, unless and until we screen more, unless and until we recognize in local languages. See, India is a lingua franca country. In Maharashtra, you speak Marathi. In Tamil Nadu, you speak Tamil. In Delhi, you may speak Hindi. And in Bengal, you speak Bengali. So you need to make a difference in the local language, creating local papa figures to make a change. And if we are committed to a change in behavior, in diabetes preventive behavior, only then we can change our numbers. That's not happening at all. People sink into diabetes, they don't even know. They sink into complications, they don't even know. The only time they realize is when they have a heart attack or when they are likely to go for a dialysis or they have a neuropathy. And that's not fair. I think it's important to recognize that diabetes is equal to heart attack. And when people recognize that diabetes is equal to heart attack, that's the time you will get seriousness about diabetes. Unfortunately, I'm not seeing that happen at all. And I think that's very, very sad. And beyond that, my only criticism to the government is the food processing industry is promoting sugar. They are saying that we are consuming less sugar and therefore we should increase the consumption of sugar. So, you need to really be mindful of what we talk. There has to be a NOC of the health department whenever such advices are there. There has to be a very strong collaboration between the food industry and the food department and the consumer industry and the health department. And health department has to be a watchdog of what is being advised, how it is being advised. Look at the advertorials which are coming out, which are the influencers for our small children. These advertorials have no regulation. So we really, if we are committed to good health, for a better movement, I think we need a willpower and we need empowerment. So we need willpower and empowerment from people who are in positions of power, including all of us. We can make small little changes where we can make a difference. And I think we are all committed, but I think that commitment is not sufficient to dent our numbers. Otherwise, we would have seen a larger dent in numbers. We are just sinking into it as a part of our day-to-day life. Unless and until we wake up and make a difference, I don't see this happening.
Thank you so much. Right. So you did tell us about how prevention of diabetes and how these advertorials, especially which are actually influencing children. We're going to come back to that, but we're going to shift gears a bit For 30 minutes, our audiences listen to what are the problems in India. Now let's look at something which they always want to be. So 30 years back, if we asked a teenager in Bombay what you want to be, he would say Amitabh Bachchan. A medical graduate in 2020, if we ask him what he wants to be, he says, I want to be Shashank Joshi. So that's the difference. So now I'm asking all of you all, what is the success mantra? There are a lot of people listening. Shashank, to start with you, what is your success mantra? If an intern is asked, he says, I want to be like Dr. Shashank Joshi. And he comes to you and he asks, I want to be like you. Now, what will be your genuine thing to tell him that how can you be like me?
So I think, to be successful, you need to have a passion and you need to work hard. And if you have the passion and love your branch, I love medicine, I love endocrinology, and I'm very passionate about it. For me, it is like everything. I breathe, live, and talk endocrinology. And I think I also talk medicine. So I think I'm very committed. So I think you need a 100% commitment, 24/7, 365 days, and work hard. I think if you work hard, stay humble, stay simple, I think sky is the limit.
Thank you, Shashank. Dr. Wangnu, your take. Your student comes to you and tells you that I want to become like you. What will be your...
I always tell them, remember ABC. A is the availability. When you are working in a hospital, you have to be in time, spend your time with the patient, listen to the patient properly. Don't be in a hurry. Each and every symptom of the patient tells you has to be heard very patiently, because every symptom tells you a different story. That is number one. B is the behavior. When you're talking to the patients, you have to have an eye contact with the patient. And the patient 50% feels better if you talk to them in a very polite manner. That is important. And C is your competence. Knowledge never ends. Even at this age, we keep on reading books because we have to teach our students. Knowledge never ends. It is not that you are practicing for the sake of money. You are giving so many new lives to your patients. You have to be up to date in your knowledge. As Shashank always has already said, that passion, commitment, and the serving to the humanity, that should be the motto in your life. And I'm sure you are going to be successful in your clinical practice or in any of the hospital you're working. Remember ABC. Thank you.
Thank you so much, sir. So, Dr. Mohan, sir, if your tips on how to become Dr. Mohan in future.
So I think a lot has already been said, but I would say that one of the most important thing is to have empathy. To have compassion, because that I think will be one difference between our profession and other professions. See, in any profession you can make money. Probably in other professions today you can make much more money than we can. As an endocrinologist, as a diabetologist, you have to see patient by patient by patient. So we are actually like paid laborers. If you sit at home and don't do any work, your income will be zero. So it is not, whereas you can be just a director of a company or an IT company running it, others can work for you and then you can make a lot of money out of it. So it is going to come through very hard work. And one of the things that you have to do is, apart from the passion and the hard work, which Shashank mentioned, is to have focus. Because today, if you're just an ordinary doctor, you're not going to come up. The competition is very, very stiff. Imagine when there are 50,000 surgeons already, you are now becoming the 50,001st surgeon. How are you going to rank in the first 100, 200 surgeons? You have to find a niche area. You have to focus on something which others have not done and become world class at it. So that is why I believe the Malcolm Gladwell's 10,000 hour story, so if you ask Sachin Tendulkar, he would have done the same thing. If you ask Anil Kumble, he would have done the same thing. And I asked actually Geet Sethi whether he actually did it. And he said it actually turned out that it was after 10,000 hours that he won the first world championship. So I think that rule is quite true. And if you keep on focusing on doing something 10,000 times, you will become one of the world's best in your particular area. It couldn't be an endoscopy, it could be something else that you're doing, and so on. Of course, for me, research I cannot leave out. So the very few people are doing medical research in India. There's so much of opportunity. Indian medicine is so different, whether it's cardiology or nephrology or hepatology or any specialty you take, endocrinology, it is so different. Our phenotype is so different. If you just systematically start analyzing and collecting your series, then you become very good. The moment you publish something very good, you are known immediately. So that is another thing that you can do. As Dr. Vangnu mentioned, a clinical history. Today, we're not even touching the patient. We sit away from them and then we think that we can just do something. Holding the pulse of the patient, it may not be just for the pulse alone, but your kindness, you're transferring much more when you actually touch the patient, pat the patient, say, well done. This is what patients are coming to us for. Otherwise, they don't need us. They can go into a computer, learn everything tomorrow. Just like WhatsApp University, there'll be a computer university. Put your symptoms, you'll know this much, buy this medicine, order it online, and then you can take your sulfonylurea or SGLT2. So that stage may come, but it can never replace the human touch. Artificial intelligence cannot replace real intelligence, real compassion, real love. I think that is where, if we really can, it's not putting on a show. We must really feel for the patient. We are in a profession where nobility is associated with this profession. Kindness is associated with this. Love is associated with this. Bhagwan Baba, my guru, says, love all, serve all. Everybody you have to love. Okay, help ever, hurt never, he says. Those 8 words summarize all that a good doctor has to do. And so if you do that, I think you will definitely come up, because not that most of the people are looking at, when they see a patient walk in, how much can I milk this guy out of? I've heard this happen even in charitable institutions, even in so-called spiritual organizations. I've seen this happen. It actually happened. I don't want to mention which spiritual organization, but there's a guy outside, and the people sitting outside heard this doctor say, it's supposed to be a spiritual organization. Okay. And they're asking, how much can you milk that guy for? I heard this in Rameshwaram when I went with the ashes of my wife. I was sitting there after doing all the rituals. I brought the ashes, and I heard the big priest inside asking the small priest, how much do you think we can extract from these fellows? And I'm sitting there with the ashes of my wife, and that fellow is asking how much money he can take from me. So it's not only in the medical profession, right inside the sanctum sanctorum of one of the holiest temples, it is happening. So that if we forget and say, money will come, fame will come, everything will come if you focus on the patient, you focus on being good to the patient, and then you work hard. And as Dr. Vangnu said, there's no limit to reading. Knowledge is changing every week. Take COVID. Every week we're learning something new. So we keep on learning till our last breath. We should be learning. If you do that, I think anybody can reach the pinnacle of success and never be in a hurry. There's no shortcut. You can't advertise, spend 5 lakhs on advertising and think you will do that. It won't sustain. They will see through you when they come. So keep on working hard, and like bees, collecting, they will all come to you. The patients will come to you.
Dr. Shubhankar Chaudhary, I want to be Dr. Shubhankar Chaudhary 2.0. What should we do?
My usual response to that is, my blessings will be for you to be beyond Shubhankar Chaudhary. Shubhankar Chaudhary is not enough. I mean, it's reasonable, but there's much more to be done. So you should be aiming at higher. But at the same time, and I think all of the others have already chipped in, but some of the important points that I have felt is what Dr. Mohan just said, that you need to have patience as well. You just don't achieve this overnight, can't be. Secondly, being true to your patient, that's very important. And also try and learn from your patients as well. I'll just give you a very small example, which may not be related to diabetes. I saw a young lady some time back who came with high prolactin. And then I asked, are you on some drugs? She said, yes, I'm taking this, which can cause high prolactin level. I said, you stop them. And you recheck the prolactin after 7 days. So initially the prolactin was 150. And after 2 weeks, she rang me and said, it's come down to 80. So I said, no, still 80 is not good enough. Then you should have an MRI scan to see if you are having a prolactin. So that young lady said, doctor, it has come down from 150 to 80. Can we not wait another 2 weeks and recheck the prolactin and then decide? Your standard textbooks, international consensus statements say you stop for 48 hours and then you can recheck. So I waited for, instead of 2 days, I waited for 2 weeks. But this lady said, why not wait another 2 weeks? I said, yes, why not? If it's coming down, let's see. And then after 2 weeks, she did ring back and say, it's 16. So it just come down. So we need to learn from our patients as well. So each time we see a patient, we have to keep our senses, everything open, so that we can learn from them. And of course, we need to respect them. We need to respect their time. Dr. Wangnu must be a very busy practitioner. But at the same time, we need to remember the patient who is coming to me has also got something other things to do. It's not this. It's not the patient's only job is to come and visit a doctor. So if that patient doesn't sort of enter Dr. Wangnu's clinic on time, he or she may be sort of pulled up. Why didn't you come on time? But at the same time, when we arrive at our clinics, often we have various excuses. We have these webinars, we have these meetings, and then we arrive late. So we have to remember that we also need to be on time. We also should make the patient feel that he or she is part of the entire family of humankind. So all these things, small little things, I think will help a person grow better as a human being. And definitely you need to have your knowledge and competence and everything. I mean, all those have already been mentioned.
And thank you so much, sir. All of you all mentioned about prevention of diabetes, how gestational diabetes is a window of opportunity to intervene. How Shashank spoke about how the FICCI or all these food labelings need to change. So I'm going to start with Dr. Wangnu, sir. Prevention of diabetes should be very much high on the priority list in prevention, not only of diabetes, but it would prevent a lot of metabolic issues that come along with diabetes. How should how should the government do it? How should an organization do it? How can a community like a building do it? How can we do it? How can a lot of people are into these checkup camps. They do those camps. The data is never analyzed. The patient is never contacted. It is just to kind of project somebody. But how can we integrate, collate all this? How can we do? How can we prevent diabetes in India?
I think, Rajiv, this is a very difficult question in the sense that prevention is one thing with a huge population like India, and preventing diabetes is a huge task. Let me start. Whether we are taking help of the government organizations, whether we are taking help of the NGOs, whether we are taking the RWA, Resident Welfare Association, the society, the charity has to begin at home. Like everybody talk of the primordial prevention, primary prevention, secondary prevention, tertiary prevention. Similarly, the charity should begin at how we have to teach our children, if they're obese, about the lifestyle modification. And without asking anyone, see what is happening in your own home, at your own family. If one learns to basically start giving education and the advice about lifestyle at each home, the whole community, the whole city, the whole state, and the whole country will start doing even charity at home, and it will spread to each and every patient, because every family where there is a member who is having diabetic, if we take responsibility to take care of their children not to become obese and spend some time in the physical activity, I think half the work is done. That is number one. Number two, taking the help of the various organizations like government organization or NGOs. Prevention is a big task. I think there have been many project diabetes prevention program in the US, Indian diabetes prevention program in India, but it catered to a minuscule population in particular area. So that means that is a small percentage that they could tackle, and they showed that prevention is possible if you are trying to take care of the patient's lifestyle and everything. If we take that example, all the good results of the diabetes prevention program and Indian diabetes prevention program, and implement them right from the very beginning at our own. What I always tell my patient, charity begins at home. Second thing, we had to stress ourselves through the government organization about the maternal health and child care. I think Shashank will agree to me that maternal health is a very important aspect in preventing the development of diabetes in the near future. and with the paradox of overnutrition and undernutrition, both responsible for the inducing insulin resistance in the offspring, we have to take care of that. I think government has taken some good initiative about the maternal and child health care, and that is going on very well, but still we lack penetration in the remotest areas about the maternal and child health care system. How many patients, the newborn baby dies because of the malnutrition? How many female they die because of the improper healthcare system? I think whatever the possibility, the modifiable factor, age you cannot change, race, ethnicity, or the genetic predisposition you cannot change, but to some extent, that even if you are genetically predisposed for diabetes, a good lifestyle can modify the onset of diabetes in that particular person. So I think it is the collective effort, and the collective effort should start from your own home. And that is the best way. Doing surveys in the community is not going to help you at all, because there is no criteria, there is no vigilance what they are doing. It is basically having few people, 80 to 100, screening them for the HbA1c or sugar. That doesn't mean anything to us. We should have, in diabetes, World Diabetes Day, basically the slogan is nurses and diabetes. So what kind of a nurses can help to the community? The nurses can do education even in the hospital to all the patients who are admitted with diabetes, give them some lessons. And similarly, those persons who got some knowledge can spread it in his own family, in his own community, in his own society, so that it gradually spreads over to the whole nation. That is my view, because simply keeping on the government decisions to implement them, I think we are not going to achieve anything.
Thank you, Dr. Wangnu. Dr. Mohan, you spoke about how patient, when they spend money, they look at it as an expenditure. Do you think that if there was some tax rebate given for preventive checkups or for going to a gym, do you think more people will be encouraged to spend on themselves, invest in this preventive checks, and would not look at it like an expenditure? Do you think this can be a change in policy?
It's a great idea. Not very easy to implement, but I think it can go, you can spread the net even a little wider. For example, subsidy on fruits and vegetables. I would say, why should a fruit and vegetable be so expensive? So if a subsidy is given to the farmers who produce this, and if priority is given, I spoke to several ministers, even at the central as well as in the state level, and they say, oh, great idea. They even take notes in the flight and so on. They, oh, it's a great idea, and so on. But then nothing really happens. So instead of providing, what we of our election manifestos are that we'll give you free rice. Now, we're giving free rice, and some governments even give free television. Now, these are the two to promote diabetes. You give free rice, carbohydrate, and then you're giving free television, so promoting sedentarism. These are two things which are going to promote diabetes. If you give a free, membership to a gym or a free insurance, that is probably much better. Or a free coupon which will get you vegetables and fruits. That's probably better. So we can start encouraging healthy things and subsidizing them and making them cheap, because that is the health of the nation. It's not just for diabetes. Imagine if you take fruits, green leafy vegetables, everything. We talked about child health, maternal and child health, B12 deficiency, and almost everything can be corrected by that. So that's the first thing that they can do. The second thing is, if insurance, I don't see why insurances can't come forward to do that. You take Middle East, Abu Dhabi, you take Dubai, you take Muscat, you take any of those places, people don't pay. They only pay an insurance, and built into that insurance is at least 4 checkups in a year, where they will say, all right, for this checkup, you can spend 50 riyal. Okay. Beyond that, you have to pay on your own. It's like a co-pay system. So they will have certain tests done. So HbA1c will be done twice a year. Sugars will be done every time. Once in a year, an eye and a kidney and a feet will be looked at. All this is free. Beyond that, if you need something, you do that. Now, why do they do that? Because they find that once they do that, the A1C will come down, their own risk comes down, and they don't have to pay for the complications. Now, the problem in India is people think I have paid 5,000 rupees insurance, so I must make 10,000 out of it. That mentality has to go. When you take an insurance for a car, you don't go and bash up your car saying, no, let him pay it because I paid 5,000 or let him pay 1 lakh. So I'll go and bash up my car. You don't do that, no. You're only taking it in the event of an eventuality where something happens, you are covered. That principle people accept. And the government, for example, is already providing, many governments are already providing through their free services saying that the below poverty line will come under that. So under no circumstance will you die because you could not go to a hospital because you could not treat your heart attack or something. I think it is doable. And there is a big business in this also. It's in numbers. It's a numbers game. So if you're able to do that and then bring a lot of people into the net, a safety net, then if they develop a heart attack or an amputation or something, they don't go below the poverty line and they don't end into catastrophic spending, which is going to destroy their whole family. I think if these things are given priority after COVID, I think we have to have a complete rethink saying, okay, we've got 80 million people with diabetes. How do we cover this 80 million? How do, four companies can take over 20 million each and then say that they are covered? And then the doctors are also incentivized. Now, one last thing is that you can incentivize. We actually brought this when ICICI Prudential and I worked together with CK Prahlad, and we brought out an insurance where we said if your A1C comes down next year, your premium comes down. It's a brilliant concept that every A1C you bring down, if your body weight comes down, if whatever you bring, cholesterol comes down, your premium comes down because your risk also improves. Where they failed was, first of all, they said for the first 2-3 years, they won't cover you. So people are not interested. Okay, after 3 years, if I get a heart attack, I'll be covered, not next month if I get a heart attack. That was one thing. Second thing was they pitched the premium too high, 20,000, 30,000. They said, okay, if I get a heart attack, I can pay for that. Why should I go and pay for this? If they pitch it to the same extent or slightly more, 10% more than what a non-diabetic pays, if they have that and then cover people with diabetes, then a big thing, the people will not go into poverty if they develop these kind of illnesses.
Thank you so much, Dr. Mohan. Dr. Joshi, you elucidated on these food labelings. So Disney in the US has also made sure that its cartoon characters is not used on children's unhealthy food items. Do you think such a regulation where children easily get influenced by these characters on food items, can these be implemented? Can something be implemented to make sure that unhealthy food does not look very attractive to children?
So actually, what is happening in India is the reverse. Actually, what's happening is we have comics where we eat more, we have inculcate wrong habits, wrong tendencies. So we actually are doing the reverse in India, and therefore there has to be a sustained movement, both legislative and non-legislative. And I think as Dr. Mohan said, the politicians will distribute rice and the television, and the influencers of the consumer industry and the food industry and the FMCG is so powerful that they will actually influence the nurturing mindsets, and therefore there needs to be a sustained banning of some of these products. For example, fast foods kill fast. These fast foods are actually cruel. In school canteens, these colas, these fast foods, we need to really ban them. We need to make a movement. I agree with you that we need to have innovative ways, whether it is comics, whether it is local characteristics, increasing physical education, improving sports culture. It has to be a movement, and it has to be movement. Unfortunately, in India, the health is a subject both for the center and by the state. And if there is a very strongly willed state government, we can make a change. And I think that is doable. But and as I said, that we need tighter policies. Definitely, everything positive is always better than anything negative. So if you do a positive thing, it can definitely work. I completely agree with you.
Thank you so much, Dr. Joshi. Dr. Shubhankar Chaudhary, GDM offers us an opportunity to intervene, but somehow all our GDMs are lost in follow-up. How can we, because they follow up 7 years to 5 years later with full-blown diabetes? How can we implement this at a very national level? At least we can prevent progression.
I'd like to enter another area, but I'll do it
surely,
quickly and briefly,
yeah.
Which has not yet been touched upon. That's to strengthen the cadre of family practitioners. I mean, this is a cadre that is dwindling, has possibly gone into dinosaurus stage even. I had been to a family practitioners meeting not long back, where about 100 people were there in the room. And if I look at the age structure, probably 5 people were above 80. between 70 and 80, around 15. Between 60 and 70, probably 50 people. And then between 40 and 50, there were another 20. Below 40, there were probably only 5 or 10 people. Clearly, people are not becoming or not finding it attractive enough to get into this area. So we as a nation, we even as physicians, as specialists, we have an interest in strengthening this cadre. And the government also needs to do some sort of incentivizing the general practitioner and the family practitioner. They are the ones who can possibly play a crucial role in getting them back into the fold once they are discharged from hospital and gone out of care of the obstetrician or whoever. So that is a very important area that we, again, requires a lot of national effort, I feel. The other thing, which again, but again, this is not specifically related to GDM, but an area that we have not touched upon, is realization that environmental pollution is also possibly playing a big role in the explosion of diabetes that we are seeing. And with Trump being out and hopefully USA rejoining the Paris Accord and what all, I think we should also try in mend our own houses, as Dr. Wang Yu says, maybe charity begins at home. We should also make every effort in every state to improve the level of pollution, the environmental pollution. That is also, that's not so much talked about, not so well established, but I think that's also an area where we can improve upon.
Dr. Kovil, can I add one sentence?
Please, sir. Please go ahead, please.
Yeah, what I do in my hospital, because all women, when they deliver, they are very aware that their child has to be vaccinated at every time and at a proper time and interval. So what we have done, we are licensed with our pediatricians who take care of their child when they come for the follow-up, because their follow-up is 100% because they had to get vaccinated as per the advice of the pediatrician. And we tell our pediatrician at least advise them to get a GTT done at this particular time, 6 weeks, 1 month, 6 months, yearly interval. And that has given a wonderful results. With that, we then, computed our data, okay, how many GDM who has been regularly following with the pediatrician for the vaccination and got themselves test as 6 weeks, then at 1 month, then 6 months and 12 months. We published our data initially for the 6 month and 1 year, and you can be surprised that our data showed at least 4% of GDM at 1 year they got converted into type 2 diabetes. That is important, otherwise we would have missed them. And this is one way, because you told, because they lost to follow, but they will not lost to follow because of their child. They has to be properly vaccinated. You have to liaison with their pediatrician in the hospital or with the family physician and tell them to please tell them, even if they don't visit the physician or endocrinologist, please tell them to get the GTT at proper interval, give them a pamphlet. And this has done wonders. And we have a huge data collection in our hospital now. And we are compiling our data. And I think in near future, you will have very good data to show to the world as per the India, how many percent of GDM goes into IFG, IGT, type 2 diabetes, or the remission rate. So this has done really good thing in my hospital.
Thank you so much, Dr. Wangnu. Let me thank all of y'all for the excellent deliberation, which actually came from the heart rather than from the mind. All the delegates who watched would have got novel ideas on not only to practice, but also a complete overall change in how they could actually approach patients. Thank you so much, Dr. Joshi, Dr. Mohan, Dr. Wangnu, and Dr. Chaudhary. Thank you very, very much. I hand it back to Dr. Prashant Agarwal for his final statements.
Happy Diwali to everybody.
Happy Diwali to everyone.
Happy Diwali to everyone.
Stay safe. Today is the World X-ray Day of the Rowan Jones Gray. So it was the X-ray vision from Rajiv. Congratulations to you, Rajiv.
Thank you so much. Thank you so much.
Thank you very much.
Thank you.
Thank you.
Yeah, Dr. Agarwal, over to you.
Thank you, everyone. Thank you so much for this wonderful session. And special thanks to Dr. Rajiv Kovil sir for beautifully moderating the session.
Thank you so much.
And of course, all our stalwarts, I mean, they have shared their experience and what they actually want from the society, from themselves, and from government. And definitely all our audience who have listening to this program, they will make some changes to their day-to-day practice, and which will help definitely better diabetes management. So thank you, sir. Thank you, everyone. Thank you
Thank
all.
you.
And
Thank you.
happy Diwali, sir.
Thank you so much.
Thank you.
Bye-bye.
Namaskar.
Bye-bye. Bye-bye.
Stay safe, everybody. Bye-bye.
Bye-bye, sir.
Thank you, Dr. Prashant.